I have prepared based on the National Program for Prevention and Control of Japanese Encephalitis and AES guidelines that was issued in 2014. During my previous talk, you could have seen that I was using the term AES and also Japanese encephalitis, acute encephalitis syndrome and Japanese encephalitis. So prior to 2003, acute encephalitis syndrome and JE were synonymously used or were interchangeably used. But only in 2003, we had a program for JE, and 2006, that's where the distinction of AES and JE were made, when the laboratory facilities were enhanced in the country, and we had the other etiologies for AES that was occurring in the country. So AES is the generic term that we use for the clinical presentation of a disease which is characterized by high fever with altered consciousness. Like this can be compared with like fever. Malaria can have fever. Malaria presents with fever. Typhoid presents with fever. Common cold presents with fever. So similarly, AES is a syndrome. So many diseases can present as AES, and JE is one among them. So the picture says the TB meningoencephalitis can present as AES. Encephalitis can present as AES. Viral encephalitis can present as AES. TB meningitis, Haemophilus influenza B can present as AES. So there are many other diseases apart from Japanese encephalitis which can present in AES. But in India, the Japanese encephalitis is the primary cause of viral encephalitis in India. So what does the national program say? So it has a it adopts a multi-pronged strategy. So it involves other ministries such as Ministry of Drinking Water and Sanitation, Ministry of Women and Child Empowerment, Ministry of Social Justice. So it is bringing many other ministries into the program so as to bring convergence. However, Ministry of Health and Family Welfare has been designated as the nodal agency, and our National Vector-Borne Disease Control Program has provided the operational guidelines that will be adopted by all the personnel who are engaged in the prevention and control of AES. Also, the program has a primary focus on the 60 high priority districts in 5 states. The 5 states are Uttar Pradesh, Bihar, Assam, West Bengal, and Tamil Nadu. So I mentioned a multi-pronged strategy. So what is the multi-pronged strategy based on? The multi-pronged strategy was based on 1, prevention of cases. 2, if the cases occur, early diagnosis, early referral, and prompt clinical management of cases. And finally, those who develop physical disability, a proper rehabilitation for those children. So this is the premise on which the strategy was developed. So for preventing AES, the first strategy was to strengthen the surveillance for both JE and AES, and to strengthen and expand JE vaccination in the JE endemic areas, and to better manage vector through control measures, and also to institute BCC behavior at the community level, especially emphasizing on promote early case reporting, referral of cases, and use of personal protective measures. Then the case management part, where it again laid emphasis on early diagnosis and proper management of JE cases, management of JE cases to reduce case fatality. Finally, those children who have mental and physical disability, counseling and rehabilitation for them was planned through the. If you look at the AE's definition, it is the same definition as that we have talked earlier. So there is an acute febrile illness episode and a change in mental status. As I have told you, there can be confusion, disorientation, and inability to talk, and or with new onset of seizures. And in WHO guideline for JE surveillance, AES syndromic surveillance approach is recommended from the WHO. The AES syndromic surveillance is recommended, and similarly, the program also gives guidelines for AES syndromic approach, so that we will know of the AES how many are due to JE and how many are due to non-JE etiology. So this is the strategy that the probable cases, the probable AES cases, fever with altered consciousness, when they reach hospital, they have to be investigated and confirmed through laboratory investigations. So then we will know uh, uh, those who are negative for all the blood parameters and those who are positive for some parameters such as Japanese encephalitis, Haemophilus influenza B, measles, varicella zoster virus, etc., etc. So if you see the AES case classification, uh, whenever we come across a case, so it is very highly recommended and advisable that we send the CSF or blood sample for investigations. So they will be investigated primarily for IgM against the Japanese encephalitis virus. If it is positive, then it will be labeled as lab confirmed JE. If it is negative, then they will be tested for other etiologies such as measles, mumps, varicella zoster, Nipah, etc., etc., and they will be labeled accordingly. And if a particular AES case, we are not able to take blood, then if they are geographically or temporally, if by time and by place, if the case is coming from the same village where we have a laboratory confirmed case, then we label them as probable G. If there is no link, then we carry it as AES unknown. So the AES and JE surveillance has three components: the epidemiological surveillance, the entomological surveillance, and the veterinary based surveillance. And primarily these surveillance are carried out exclusively through program in the 60 high priority district. Otherwise in other districts, in other endemic districts or non-endemic districts, it is through the normal IDSP reporting. So what is we do in an epidemiological surveillance? The basic premise is the health institutions, both the public hospitals and the private hospitals, has to look out for patients who are presenting with signs and symptoms of encephalitis. So once they present to a hospital, it has to be identified and notified to the nodal officer of the district. And the nodal officer then investigates the case and arranges the sample collection and laboratory investigation. In such a way, the line listing of cases that occurs in the districts are done, and the data is analyzed in terms of time, place, and person, and we compile the outbreak report so as to institute appropriate control measures. We have to always remember that we do surveillance so that we will know the distribution of cases in terms of time. When does it happen? Whether it happens pre-monsoon or post-monsoon. Place, where does it happen? Where does it happen in Odisha? Either in the southern part or in the eastern part? Or if it in the districts, in which areas of district does it happen? Person, who is affected, children or older age group. So when we have a very systematic way of collecting data, when you have a very robust surveillance, then the data can be analyzed so as to institute appropriate control measures. Also, for example, we have introduced a vaccination in our state, and we want to know the impact of vaccination. The surveillance helps us to provide evidence on the impact of vaccination over a period of time. So after vaccination, whether the cases have increased or decreased, and that can be known from the surveillance. So epidemiological surveillance for JE, they have planned as a sentinel surveillance. So there will be sentinel sites with laboratories and without laboratories. So the sentinel sites will be government or private health facilities which are engaged in treating large number of AES patients. It can be the medical college, it can be the district headquarters hospital in the district, or a private hospital where large number of patients come, but it should have a laboratory capacity to diagnose JE. At least IgM capture ELISA should be done. The facilities to do IgM capture ELISA should be present to to qualify for a sentinel surveillance site with laboratory. So in India, 78 such sentinel surveillance sites have been identified. So in each of these sentinel surveillance sites, through the program, there is a designated nodal officer who coordinates these activities. whenever a case with AES like symptoms present to that institute, he makes sure to investigate the case, make sure that the sample collection is done, and he does the line listing of cases. Then he documents AES reported patients and deaths, puts the aggregate number, and reports to the next higher level. But again, through epidemiological surveillance, we create a network where we can capture cases. So one such network was sentinel surveillance site with laboratories, and there can be sentinel surveillance sites without laboratories. So these can be facilities, both public and such as PHCs, CHCs, that treat patients but do not have lab facilities to confirm JE. So what these sites are expected to do is whenever they come across a particular case, they have to investigate the case, notify the case, collect sample, and send the sample to the nearest SSL. If there are danger signs, then the case has to be referred to the nearest referral unit. Apart from these well-established units, we can have informer units, smaller facilities, private practitioners, pediatricians who treat AES. So we will sensitize them regarding the AES definition, and whenever they come across a case of AES, then they will report that to the district nodal officer, the VPD officer, or the surveillance medical officer. So the program mandates that all notified cases should be verified and investigated by a specific, specially trained VDB officer, district vector-borne disease officer, within 48 hours of notification. So once we do this surveillance, we get a line list of cases and we get aggregate number of cases. So these get aggregated at the district level, state level, and the national level. If you remember my presentation in the earlier, the first part, where I have given the number of cases for India, both AES and JE, and for Odisha, that was through this surveillance network, the surveillance network that was established through the NVPDC program and also through the IDSP. So this is how the cases are picked up from the community by the hospitals. They are lab confirmed or not lab confirmed, then they are reported at the district level. Line list of patients are collected. They are then analyzed. Then they are then sent to the next higher level for compilation. But however, there are some monitoring indicators. One, completeness of monthly reporting. How complete is the monthly reporting? And timeliness of monthly reporting. In outbreak situations, every week the report has to be compiled in the specific formats. There are formats, AES format 1 to AES format 3, then other formats that has to be filled every week during outbreak, in transmission period every month, and during the feast and during the other times monthly ones. Then the percentage of serum sample taken. How many cases were detected by the system, out of which how many samples were sent for laboratory confirmation. And proportion of AES cases that were tested for AE. How many samples that were taken and out of which how many were tested for JE. Then the data collected can also help us in analyzing data on percentage reduction of CFR in the particular district. So that was about the epidemiological surveillance. The epidemiological surveillance, where we create a network to detect cases, identify cases, collect sample, and classify them whether they are JE positive AES or JE negative AES. Entomological surveillance, the objectives are to identify the JE vector mosquitoes in an area. So if you remember, that's what I was asking you repeated questions. What is the vector that is contributing to JE in Odisha? Is it Culex or some other species, or is what is the the vector mosquito in the particular area? And it also helps to monitor JE vector abundance in JE endemic areas, and to detect JE virus in the vector mosquitoes, to isolate virus from the mosquitoes. And all this will help us to institute appropriate vector control measures. So who is responsible to do the eco-entomological surveillance? The entomologist and the insect collectors or the biologists or the national filaria control officers in the district are responsible. And if the district has the NIMR field unit, National Institute of Malaria Research field unit, they can also support in collecting the vectors. So there are some set guidelines for the identification of index villages. So in these villages, the surveys or the vector surveys are conducted periodically. Those villages where JEs occurred in the past 5 years, or and 2 villages with no GE till monitored in the affected block. Some sample collections occurs on the sample collection occurs in these villages on fortnightly basis to know the vector density, the resting behavior, feeding behavior, and whether the particular mosquito is infected with the JEV virus or not. So they do an adult survey, they do larval surveys, and they map the breeding sites where they breed. Either they breed in the irrigation channel or the rice fields, paddy fields, or in small ponds, which is aquatic ponds with aquatic vegetations. So they do these larval surveys to identify the places of breeding. And they also collect this larva to identify the vector species. The adult survey is done indoor and outdoor, and also during the dusk collection in bushes, plantation, and standing park crops. And they do by hand catch method. And we look for the vector density using the PMHD unit. And this is monitored over a period of time and reported accordingly. So laboratory investigations. So once we catch these mosquitoes, we try to isolate JE from this JE vector mosquitoes, and this happens at the reference laboratories. Third is the veterinary surveillance. The objectives of doing the veterinary surveillance is to understand the prevalence of the pigs and the water birds in a particular area. And also we can detect, is there any viral activity in the susceptible host and the reservoirs. So what we do periodic assessment of density of population, density, the pigs or ducks density in relation to human habitation. Whenever there is a higher density observed, then the whole mitigation measures are instituted. Then we collect sera from these animals. Basically, veterinary department is responsible for carrying out the surveillance to ascertain whether JE virus transmission is there among the animals for early warning signals. Remember, we do all this surveillance so that we can pick up the cases early and we can avoid large outbreaks. So, as I told you, early warning signal. So we do different surveillance. We do surveillance in humans, we do surveillance in the vectors, and we do surveillance in the animals, so that we can pick up early warning signals. If there are early warning signals, then we can act early and prevent cases. For example, if you see in the picture, if we can act early, only the red, only the picture colored in red, those number of cases will happen. If not, if we act late, then the whole curve will become red. So if we act early, the yellow indicates the number of potential cases that we can prevent because of the early warning signals that we detect through any one of the 3 surveillance. So what are these early warning signals? So reporting of a suspect case with a clustering in time and space which do not fit into expected known endemicity or seasonality of JE in a given area. We have a surveillance. Generally, our network picks up a lot of JE suspected case, which is not usual in a particular area, then that's an early warning signal. Also, if there are fluctuation in ecological conditions, heavy rainfall, followed by conducive for vector breeding, or sudden change in the agriculture practice, where instead of other crops, they are doing rice, and so there is a lot of standing water, then that can enhance the adult density of JE vector. So that can be an early warning signal. So increase in vector density of pigs in good number, amplifying both the pigs in good number can be an early warning signal. And through vector surveillance, we find there is a detection of viral activity. Again, that can be an early warning signal. And detection of viral activity in zoonotic reservoirs, the water birds, ducks, if you find a viral activity, then it can be an early warning signal. So what do we do in outbreak investigation? The moment we detect a early warning signal, then rapid response teams are constituted for investigation and the containment of an outbreak. So as a part of investigation, we first confirm the outbreak, whether is there really an outbreak or there is a false alarming of cases. So we detect the outbreak. If the outbreak is real, then we proceed on to lab confirm those suspected cases. Then we demarcate the area that is involved in the outbreak. Then we list the cases, report the cases. Then we also assess the presence of reservoir host. Why is there a sudden increase in a particular outbreak in a particular area? So to look out for that, we will see is there any presence of reservoir hosts such as pigs, poultry in the nearby vicinity of the suspected areas. Also, the vector surveillance to see the vector density, type of vector species, the viral activity in vector should be initiated immediately. So as a part of containment measures, we have three measures. One is to minimize the mortality and reduce CFR. Other is to start community awareness, and the third is the vector control measures. So to minimize mortality and reduce CFR, we have to make sure the appropriate clinical management of cases. We have to alert our tertiary care center and the secondary care centers to be ready with the appropriate logistics to manage the case, and the referral has to happen without any delay. And we have to start the community surveillance in that outbreak area first about the reporting occurrence of any case. If there are any case, the community leaders or the religious leaders, the community members should be sensitized to report them, not to hide them. And promote personal protective measures such as protective clothing, using mosquito nets, wearing full sleeves, using repellents, moving away from piggeries. So those measures can be instituted. Finally, whenever there is an outbreak or a case in a village, the vector control measures has to start. And the only vector control measure that is recommended for JE is fogging in the affected village. So this was the first part where we prevent, we have a surveillance, so we know we can early detect cases and institute appropriate measures. The second strategy that is adopted by the program is vaccination, the most effective way, the most effective tool to prevent JE. So human vaccination is the most effective tool for the control strategies, and in India we have three vaccines. One is the ACA 1442, the Chengdu vaccine. The other two is the Genvac and JE, which are the inactivated vaccines. So looking back at the introduction of JE vaccine in India, Gorakhpur region in UP in 2005 experienced a very, very severe outbreak. There were more than 6,000 cases and there were around 1,300 deaths. So that's where the government of India decided to introduce the JE vaccine in 2006. So it was introduced in 11 most sensitive districts of Assam, Eastern Uttar Pradesh and Karnataka. So 1 to 15 years children were given the vaccine in a campaign mode in 2006. And in 2011, the JE vaccine was introduced in the routine immunization program, initially as a first dose strategy, and in 2013 as a second dose strategy. Now in a routine immunization program, JE is given along with measles at 9 to 12 months and along with the DPT booster and measles booster at 16 to 24 months. The document says that till now, this is by 2014, that around 132 districts have been already brought under JE vaccination. But we know that it's not 132, but many more districts are now have been brought under JE vaccination. Even I was surprised to see that 24 of 30 districts in Odisha have been brought under JE vaccination. So the second component of the program was to strengthen and expand vaccination. So as to expand vaccination, so as to prevent JE due to migration. The third, the another strategy that was proposed is the vector control. And the vector control has to be planned after studying the bionomics of vector mosquitoes in the area, whether they feed indoor, where they rest, whether they are resting indoor, outdoor, where they rest in the vegetation or inside the house, has to be studied And the risk of transmission increases if the human dwellings are proximal to animal sheds, particularly piggeries. So if those people who are staying near piggeries have a higher risk of contracting JE. So those interaction has to be minimized. And due to the outdoor resting habits, the natural IRS spray, the indoor residual spray, is not possible because it rests outside in the aquatic vegetations or normal standing crops. And due to the vast and enormous breeding habits, larval control measures is also not feasible because it breeds in the clear waters, and we have clear water everywhere in forms of ponds and in paddy fields and other water bodies. So larval control measures is also not feasible. So only recommended method is ultra low volume fogging that can be used in the Japanese epidemics, and the document clearly says even with the one case that is reported in the village, we have to start with fogging immediately. So the last part, the rehabilitation part, program talks of rehabilitating the surveying disabled children as an important objective of the program. So in order to rehabilitate, they have put forth two things. One is the physical, medical, and rehabilitation department in medical colleges, where where physiotherapy or physiatrist will help these disabled children or rehabilitate these children for speech therapy, for hearing therapy, for physiotherapy, etc. And they have proposed to establish counseling centers in the high priority districts at the district hospitals for counseling the parents and the children of post the disease. So I have come to my last point. The whole program says prevention is the key. Why prevention is the key? Because there is no specific treatment for disease, and vaccines are very crucial to prevent JE. Just to reiterate, vector-borne Japanese encephalitis is a vector-borne zoonotic viral disease. It is viral disease because it is caused by a flavivirus. Vector-borne because it is transmitted by mosquitoes. Zoonotic because it is transmitted from the animals. The virus is transmitted from the animals to the humans through the mosquitoes. Mostly it occurs in children because adults have immunity against the JE virus, and it affects the brain. So it affects the brain, and it has a very high case fatality. Since it is affecting the brain, post-disease, many of them have physical and or mental disability. So vaccines can prevent JE, so we have to make sure that our vaccination coverage is highest in our district. Again, I acknowledge Dr. Rupa Kumari, Technical Officer WHO, and Dr. Kamran. I have based my slides on their previous presentations. Thank you.